Bhargavi, is it live?
Yes, Dr. Someshwar, it's live.
Yeah, thank you. Dr. Shreya, ma'am, with your permission, shall we start?
Yes, yes, definitely.
Yeah, thank you, ma'am. Good evening, doctors. This is Dr. Someshwar from Shield Healthcare. I welcome you on behalf of Shield. Thank you very much for joining today's webinar. I request all the participants to post their questions in the comment box so that at the end of the webinar, we'll have a short Q&A session. So now let me welcome today's our eminent speaker, Dr. Shreya Bhattacharya, ma'am. We are very honored and very glad to have you for today's webinar, ma'am. She have done her medicine from Lozo Medical College and also completed her DNB in gynecology and MNAMS. And she worked in various hospitals. And currently, she is working as a senior consultant at Indira IVF Hospital, Kolkata. And coming to the membership, she's a member of Bengal Ops and Gynec Society. And coming to the training, she attended various training like ART and AM, and also participated as a delegate in post 2014 and attended FOXY gestosis and undergone 3 weeks training in Department of Gynecology and Oncology at Chittaranjan National Cancer Institute, and also attended workshops on colposcopy and treatment of cervical neoplasia, and also participated as a delegate in Boxcan, and also participated as a delegate in the 58th All India Congress of Obs and Gynecology at Chennai, and participated as delegate in Endo Gynecology 2015, and also attended All India PG training program Focus 2015, and also undergone 15 days training on VSG, and also actively participated as a delegate in workshops of electronic feature monitoring. And also she won second prize in ISO PRB quiz competition. Uh, and coming to the publication, she have various case reports on autoimmune hemolytic anemia in pregnancy managed by blood transfusion and oral prednisolone, and also case reports on cryptomenorrhea, and also case reports on non-immune eye drops. So with this, we welcome you for today's webinar, ma'am. So before proceeding, we have a short introduction regarding the Shield Connect, which is a dynamic platform to connect all the doctors at one place. And this is a digital initiative from the Shield where you can find the webinars, the past and upcoming webinars. And if you miss any part of this program, you can always find it in the Shield Connect. And also we have awareness pages regarding the current COVID-19 updates and immune booster, PCOS, infertility. And also we have our leaders page where you can find most of the KOLs and key opinion leaders who are supporting this digital initiative. So with this, I welcome you on behalf of Shield. And today's topic is poor ovarian reserve and oocyte quality. As we know that poor ovarian reserve is one of the most challenging problems in reproductive medicine, and as we know that it's uh, the not only the quantity, also the good quality oocytes also restricted in POR. So now, without wasting much time, let me turn over the time to Dr. Shreya Bhattacharya ma'am to talk on poor ovarian reserve and oocyte quality. Over to you, ma'am. Hello. Ma'am, your voice is not audible.
Hello, Shreya ma'am. Hello. Hello.
Hello, Dr. Shreya, ma'am.
Hello, am I audible now?
Yes, ma'am. You're audible now, ma'am. You can share the screen, ma'am, and the video as well.
Yes, I seem to have lost. Right. So my screen is visible, I hope.
Uh,
Hello.
yes, ma'am. I mean, you have to do the screen share. I mean, the slide. Yes,
Hello.
yes, ma'am. It's fine now.
And now it's fine, ma'am.
Okay, fine. Okay, so I don't know if the previous part was okay, fine. So today we'll be discussing poor ovarian reserve and poor oocyte quality. Now, reserve a lot more now, and it is also at a later age, women are choosing their careers over thinking of conceiving at a later period. So as a result, is already at we are also finding poor ovarian reserve even in normal, like younger age group females. So before we go into that, let us first understand it. Now, ovarian reserve in her ovaries and what potential does she have to conceive? So it is a functional potential of the ovary. It is basically measured by one is another is the AMH, the ovarian hormone that we measure in the blood. Now, why does this ovarian reserve go on decreasing? The basic physiology is that women are born with a finite five. After that, this deceleration is occurs faster, and she loses her eggs at a faster rate until she reaches her menopause when her reproductive potential is over. Now, why does this reason is that every cycle she's ovulating a number of follicles are getting recruited in that cell are getting removed from her ovarian pool. And there is also another few follicles go on getting damaged and are removed from the ovarian pool even without even over and above the number that is getting recruited and the ovulation that is occurring. This follicular atrophy or 38, like it is in the mid or late 30s. It is considered to be between like 35 to 38 in accelerated, and her ovarian reserve drops at a much faster rate. So what happens is that, like it has been explained, the poor ovarian reserve indicates a follicles. Though by AMH and AFC we cannot comment on the quality of the follicles, but the number of follicles are less. That is when an when in ovarian stimulation, the number of follicles is also decreased, and the potential of having a euploid, that is also decreased with decreasing number of oocytes retrieved. So it is just being unmasked by the increased acceptance of IVF. More and more couples are coming forward for IVF and having their ovarian reserve measured. And also there are also women who are not getting evaluated. So those percentage of women actually having poor ovarian reserve than what is getting diagnosed. Okay.
Shreya ma'am, sorry for the interruption, but I guess the
So
bandwidth
the
is
thing
low,
that I've
ma'am.
been telling, age is definitely a factor. There are also other factors because, sorry.
Ma'am, your bandwidth is low, I believe. There is interruption. I mean, there is a voice break in between, ma'am. Hello?
Is it better now?
Yes, ma'am. I mean, the screen and everything is visible, but whenever you speak, there is a voice break in between, ma'am.
Is this, am I audible now?
Yeah, now you're audible, ma'am.
Okay, fine. So, as we were explaining, there are other younger age group, that is women in her 20s or even early 30s. The other risk factors can be any history of ovarian. Sometimes we find women who do not have any other ovarian cystectomy or any other or medical or surgical history, but still her ovarian reserve, even at suppose the age of 33, her AMH is 1.02, something like that. So there's always a familial predilection, but apart from that, really anybody. And so everybody after a certain, okay. Now these are the common causes of a diminished ovarian reserve. Like the most common is obviously the advanced reproductive age. One factors like smoking and any exposure to chemotherapy, radio ovarian reserve. And also any surgeries like an ovarian cystectomy. PC1 was treated by ovarian drilling, and subsequently at a later age she landed into a and of course tubal surgery can also be a reason, because during tubal surgery disturbed, resulting in a diminished ovarian couple. There is any genetic disease in which is there, the patient will not have any symptoms, but check the FMR1 gene mutation, which will lead to. We all know that age is definitely a factor. With age, the ovarian reserve is bound to diminish, but it varies with woman to woman. Sometimes we find a good ovarian reserve even in the older age group. Like we recently had a woman at 44 and we stimulated her and we retrieved around 10 to 11 oocytes we have retrieved, and ICSI was done on the advised her a PGTA because of her advance with increased maternal age. So we have, and we are still awaiting the result. Have an ovarian reserve, but of course it will sometimes people who have a higher reserve may still have enough ovarian reserve after 40 also, that we can think of IVF with herself oocytes also. So moving like the previous slide explained, that with age the follicles are going on decreasing. It was highest at birth, not even at birth, at it down the intrauterine life. And fertility is generally reached in the late time. Decline occurs mostly from 35, 38 onwards. And finally, it is can be 45, 50, 55 even. So that is when the ovaries become senescent. Like we do a TVS scan, the ovaries are hardly visible. There's hardly any AFC
Shreya ma'am, there is still network issue, ma'am. In between, there is voice break.
As I said, the number of oocytes is also, sorry, hello.
Ma'am, we can't hear you fully, ma'am. I mean, one sentence would not be completed entirely, ma'am. There is a break in between. I guess there is a network issue. Yes, ma'am.
I think there is some network issues I'm having Wi-Fi. I hope I'm audible, then I'll continue.
Sure, ma'am. Yeah.
Hello.
Ma'am, please continue, ma'am.
Yes, ma'am, you're audible.
Okay, then I'm still at the clinic, so I'm not able to use the Wi-Fi. Hello.
Yes, ma'am.
Now it's clear,
Hello.
ma'am. Yeah. We, you are audible,
Hello.
ma'am.
Am
Now
I
it's clear.
audible and this other slides visible?
Yes, yes, ma'am. Now we can hear you and it's much clear. Your slides
Quality
are also visible, ma'am. Yeah.
reflects. Sorry. Okay. Thank you. Thank you. Right. So as I was saying, indirect indicator on the quality, and the quality in turn can predict the live birth rate. That is the LBR. This with the number of oocytes that are retrieved. Like you can see in the slides that when the number of eggs collected is increasing, the probability of female age is also therefore an indirect independent indicator of live birth. Like live birth is actually the final outcome of the IVF on which we determine our success rate. It is not the clinical pregnancy rate, rather it is the live birth rate. Blastocyst, like if there is an euploid blastocyst is not formed and the patient is unwilling for a PGTA, we do not. This is the number of the percentage of even though we get a pregnancy, we do not land up in a live important factor. So that is why we say that when a couple where the female partner is 35 or older, she should not be investigated, and the male partner is 35 or older, she should not be investigated and get treated. If younger, if the woman is younger, then in that case we can wait for 1 year to happen. If that does not happen, then she should get investigated and thereby, when she's in a higher age, subsequently get treated. That is what has been found out in various studies, that the probability of an euploid blastocyst decreases with less number of oocytes retrieved from one euploid blastocyst. In practicality, we actually it is more than that, because it has been seen that we need at least 10 M2 oocytes need to be retrieved to form one good blastocyst. And this negative effect of female age goes on increasing with increasing maternal age. Euploid blastocyst forming. Blastocysts, but all of them are some having some aneuploidy or some chromosomal number abnormalities for which we cannot go through with an embryo transfer. Environmental and those also needs to be looked out for during the history taking. Or things like that. These can be and there are endocrine factors also, like any pesticide exposure, and all that can actually lead to gene mutation. And any endometrioma. Chocolate cysts also can decrease your ovarian reserve. Sometimes, as we see, that it affect we have encountered where there's a young female, maybe in her is also normal, like 3.4, 3.5, something like that. But when we scan in maybe one or bilateral ovaries, and which there's hardly any follicles visible, because that endometrioma will pose a treat it surgically. Also, there is a risk that the give her gonadotropins and leuprolide monthly for like 3 to 4 the size of the endometrioma, it will also diminish her ovarian reserve. So that is why an endometrioma is a very difficult situation if she has huge difficult case to treat. And genital tuberculosis, of course, but it also to have good quality embryos formed. If the endometrium is not good, very difficult to have an implantation. And the poor ovarian reserve, of course, it leads to a poor, lower pregnancy rate also for the reason that we've explained before. That is possibility of aneuploidy. Like I said, if there is any abnormality in the chromosome number, like 18, 21, these are the common ones. So these are very common when the maternal age group increases. Especially we are worried about the trisomy 21 because those are the cases that do not land up in abortions. Implantation genetic testing of aneuploidies. Infertile couple multiple miscarriages stereotype. And if there is a known translocation or a deletion which has been found in her, in them, we're looking for structural rearrangements. Like there's any deletions are present. So when we look for a PG abnormalities, then we just go for a straight PGT. When we look for the common and so on. Okay. Now we are moving on to the studies now, which is showing that we need at least 3 oocytes to form one good quality blastocyst. Now, sometimes we've seen that we are getting more oocytes. So here in this study, what they're doing is in a few cases we're that the patients from whom the higher number of eggs have been retrieved, like 7, 8, 9, they have in patients who have lesser number of eggs. So here as I say, that C is not study where we are dividing the patients in 2 groups. In one group, we are inseminating only 3 eggs, and in another group, we are inseminating all the eggs. And it has been oocyte quality, but a certain number of right. And then we come to oocyte morphology. See, as such, there are no morphological features which different polar body and if there's any debris and these kind of things, but mainly it is the embryo that we assess for morphology. The oocyte or an M1 oocyte or it is a GV. Division is complete in the second polar body has been extruded. So that needs the neomaturation. Now there are various studies taking the embryo as such, and normally we are not, once a blastocyst is formed, we take a few cells from the proctectoderm and we check them for aneuploidy. We can any known aneuploidy. While doing our IVF stimulation during our IVF, they are getting the trigger on day 10 itself. And in some patients, we see that starting the antagonist in an ANTAC protocol, we're starting it on day 7, day 8. event sometimes because it is not reaching 12 sections. So patients are asking whether does the rate of growth of the follicle a cause for giving rise to poor quality oocytes. So in certain patients, we have seen that if we prolong the stimulation for a very long time, giving rise to poor quality oocytes. The standard rate of follicular development is 1.7 millimeters per day. So a complete stimulation would generally should terminate within 10 to 12 days. That is the optimum period where we get good quality oocytes. Okay. Test and the ultrasound, we get a basic idea about her ovarian reserve from a menstrual history itself. Whether she's because we know her reproductive period, they have irregular cycles. If she's having any intermittent hello.
Yes, ma'am. Hello. Hello.
I seem to have lost connection for a bit.
Yeah, yeah. Yes, ma'am. Your slides are visible.
I'm audible. Hello.
Hello. Yes, ma'am. Your slides are visible. Hello.
See the second or third day of the period. Then also we can check the baseline ultrasound characteristics like the ovarian volume. Are that she have a good reserve. While we when we invariably ovaries, right? And of course, the antral follicle count is there.
Ma'am, your slides are not visible, ma'am.
And on day 2, day 3 of the cycle, because if you do it mid-cycle, then LH will invariably be higher. So it will not be an indicator of a lower ovarian reserve. It has been said that type, but normally we are doing it only for patients who are having multiple miscarriages or there is any history of a anomalous baby in the past, or there is a disorder like we once had a patient who had expired subsequently, and she'd come to us for Moving on, so going to proceed with an IVF, we are checking to predict the ovarian response. We are actually basically trying to identify
Ma'am, your slides are not visible.
the poor responders. Now, we want to find out which. Okay, just a moment, please. I'll share the slides again. Wait. Now, is it visible?
Yes, ma'am, your screen is visible.
Hello.
Yes, ma'am, your screen is visible, ma'am. Yeah.
Okay, okay. Thank you so much. So, as I was saying, when we are doing ovarian reserve testing in patients who are going to undergo an IVF. Now, we'll go into the Bologna for the poor responders and also the Poseidon. Yes, so we need to unders and the optimize their treatment protocols. So, like we've already mostly not doing this basal estradiol level. We are doing that somewhere while starting stimulation, and we see like it's a basic thumb rule. If it's above 60, then in that case we do not start dominant follicle. We just do a TVS and we move on with the stimulation. Go for naming because the AMH is not cycle dependent. It doesn't matter when we are actually doing that test. And a normal AFC, we only find poor ovarian volume in perimenopausal and menopausal females. Inhibin B, normally we are not doing it as a theoretical test. We've read about it in the past, but currently, okay. So, hormones, we have seen that when the AMH comes below 0.8, the response is very poor, and in such cases, we normally advise a donor cycle. And the antral follicle, in such cases, we have to counsel the patient that the response might be level would be a indicator that we should be higher than 10 would be bad, and we'll especially we need to check that whether it's been done cycle, then is normal, so that shouldn't be a problem. Okay, so now we are going on to the Bologna patient who has any two of these belonging to the advanced maternal age, that is, if she's above 40 years old, previous history of a poor, like we said, certain studies have shown that we need at least 3 oocytes to create past history of poor ovarian response. That is also diagnosing her as a poor ovarian. An age which is below 0.5, then also she fits into the criteria. So we need 2 out of 3 to label a patient as a poor responder. That's the Bologna criteria. In the Poseidon group, it is more specific. Actually, we're dividing the poor response depending upon her age and her subsequently. So this is how start counsel a patient, and the patient decides to get the maximum number of oocytes for stimulation repeatedly, cycle after cycle, to gain 1 or 2 blastocysts, single cycle, to create maximum number of euploid of implantation. So that is our goal. Like, maximize oocyte yield increases the chance, and that could thereby increase the chances of implantation. Now, in our country, because of the call who are above 35 years, elective single embryo transfer, and in such cases, when we are transferring only one embryo, it is very important that we check for the UP. So, in such cases, I think we should go for a PGTA for all patients. Uh, Caused by the number of twin and pregnancy rate, but because of prematurity and various other morbidities, it is decreasing morbidity associated NICU admissions are selective single embryo transfer, and for that we should do a PGTA in all cases. Okay, now we are going to the Poseidon group. The Poseidon individualized oocyte number. That is the Poseidon patients in 4 groups: group 1, group 2, group 3, group 4. Group 1 and younger aged females, while the group 2 and group 4 are the older females. Now, the group 1 are the women who are less than 35 and who have a but in spite of a normal ovarian reserve and the group 1 of the Poseidon groups. Then comes group 2, above 35, but she still has normal ovarian reserve, has more than 1.2, and her AC is high. Group 3, where we have older females. So the groups are which are on the lower side of the scale are actually having lower ovarian reserve. The groups on the left side are actually the younger age females. Now, despite all this, it is being shown in the live birth is always better in a younger has. So the outcome of an IVF is always better and the chances, like I said, of a euploid embryo forming is higher. But having said that, it is always the prognosis is always, these are the four groups. Group 1 is the reserve. Group 3 is the young patient less than 5, AMH is less than 1.2. While group 4 is the older age group female, more than 35, but what we expect. So this is the four groups. Now in group 3 and group 4, because we've already found that they have a lower ovarian reserve, like their AFC is low, their exhibit a poor response. So these are the women whom we call the hypo responders. Like we are expecting a good outcome, but they are at. So we need to identify in which group the woman belongs. We can optimize their outcome. Okay, so it is very important. Like the female, like we %. So whatever be her ovarian results to the Poseidon group 2 or group 4, the chances of a positive live birth or a euploid blast forming is definitely low. Response. Same thing in group 2, we have the old patients. Group 4, we are expecting a low reserve, and that's what we are getting. Group 3, we have the young with expected low oocyte number. Okay, and apart from these four response, like she can be young with a normal ovarian reserve, and she is giving the optimal outcome, that she's giving more ovarian reserve with a normal stimulation outcome. The non-Poseidon group. So like I said, the non-Poseidon females mainly constitute 53% from whom we are getting an optimal response, and come under the Poseidon groups. That is, they are giving rise to a suboptimals, in which we see are belonging to the group 1. That is, she's young with normal reserve, but and 30% belong to the older age, a normal ovarian reserve, but she's giving a suboptimal response. 10% comes under women who are young, who have a low reserve, and of course, thereby fourth group is actually the maximum number of women whom we encounter who are older, who are above 35, who have a low ovarian reserve. So this is the basic classification. Theory is that we need to identify the low treatment. We should not like go with one treatment protocol for responders and treat them accordingly. Okay. So these are the first we need to stratify, then we need to if it's adequate, whether we are having a suboptimal number, and see, optimize the treatment. This is just a basic thing. The period PGT, the live birth rate is higher for miscarriages in the first trimester. Okay, which are done to to find out the number of M2 sites required to fill and various things that are done. So the most optimal treatment strategy which is planned with the Oocytes analog regimen, because normally see we are going with a ANTAC protocol, but it has been seen in the with the hyporesponders okay. So now talking about the non-Poseidon patients who are not or not poor response like OHSS, and in those patients using recombinant FSH only. That is also a thing which needs to be considered, though it increases the cost of treatment, but it definitely diminished, right? And in certain where FSH only is inadequate to recruit the follicles, we are supplementing it with HMG. Okay. So it is also important to we can use the highly purified version. There's a recombinant version, and also there's the urinary gonadotropins. Now I think we right now are currently in use is either the highly recombinant version. So the recombinant version, it causes and emulation. So it is important that we type it has been seen that recombinant HMG also based recombinant FSH is basically better. There are also a few things that saying that there's no effect on that, but it has definitely been shown that it has a certain effect on the OHSS also. So keeping that in mind, it is always better to choose recombinant. These things and it has been stretched. The total number of doses is lesser compared to the highly purified
Ma'am,
and the urinary HMG. So it's stimulation. Sorry. Hello.
ma'am, sorry to interrupt. Actually, your slides are not visible.
Hello.
Hello,
Yes.
ma'am, your slides are not
Yes,
visible,
Annie.
ma'am.
problem? Sorry.
Yes, ma'am. Now I can see your screen, ma'am.
Hello.
Yes, ma'am. We can hear you, ma'am. Now we can see the screen. Earlier there was no screen sharing.
Yes, right. So, like I was while using recombinant, yes, recombinant acid led to highly purified HMG and urinary HMG, and then better to go with a recombinant injections. Just a moment, please.
Yeah. Ma'am, we are unable to hear you, ma'am.
Hello.
Yes, ma'am. We can hear, ma'am. Ma'am, can I share the screen for you, ma'am?
I already shared the screen. Is it visible?
Yes, ma'am. Now it is visible, ma'am.
Okay, I'm really sorry about the network issues.
Yes, ma'am. I
From next time
understand.
on, I'll try and do it with the Wi-Fi. I'm sorry, really
No,
sorry. Okay,
it's
I'll
okay,
just
ma'am.
wrap this up quickly. Yes. So
Yeah.
the Okay. Again, we are just again I'm just repeating myself that we need to group of patients. We need to it's difficult to group 1 and group 2 more than group 3, group 4, where we are having a low result. So we have to identify group 1, group 2 individualize their treatments. So again, there's a comparison between the Bologna criteria and the Poseidon groups, which we have discussed in detail. And the group 2 is the older age group, female, and given the possible causes of reasons of a poor response that we have start the low gonadotropin dose is having a normal results. But in case of the Poseidon group 1, group 2 patients, we need to give start
Hello? Shreya ma'am, your voice is not audible, ma'am. Hello? 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 Shreya ma'am, your voice is not audible, ma'am. Hello?
Hello, is it better now?
Yes, ma'am. We can hear you now.
Hello, am I
Yes, ma'am, you are audible.
audible now? Is the screen visible?
Yes, ma'am, you are visible. Your slides are visible, ma'am, and you're audible.
Hello.
Ma'am, you're audible.
Hello, am I audible?
Yes, ma'am, we can hear you, ma'am, and your screen also visible.
We can hear you, ma'am.
Ma'am, we're not audible, ma'am. So, ma'am, we can't able to hear you, ma'am.
Hello, can you hear me?
Now we can hear you, ma'am. Hello.
Okay, fine. So as I was saying that I'm near the end of my presentation. Thank you everyone for the patient hearing, and I'm open to questions now, if any.
Yes, thank you, ma'am. Ma'am, you can stop sharing now, so that the voice will be very clear. Hello. Yeah. Thank you, ma'am, for the wonderful presentation. There is a technical gap, so uh, we are very sorry for the inconvenience. But thank you very much, ma'am, for a beautiful and very excellent talk on PIVOR and oocyte quality. Ma'am, we have only one question. Uh, that is, how do you define the poor responders and what is the AMH cutoff? Hello.
Right. See, the poor responders can be, yes, the poor hello. Yes, I heard the question. So yes, the poor responders can be identified, like I said, by the bulog 40. And if she has gone an ovarian stimulation treat, and also if she has 1.2, and if her AFC is less than 5, including so either two of these three cutoff the reserve patient, and such cases as such there's no age cutoff like even in patients who are as 38 or 35 even. So in practically speaking, we can take the cutoff is 35, after which the ovarian. So we need to actually identify poor responders by actually the history, her check her AFC, check her AMH. If it's less than 1.2, even with 0.8 also we can go with ovarian stimulation. But if it's in the range of 0.8 to 1.2, we need to be a bit careful because she question.
Thank you very much, ma'am. Ma'am, there are no more questions from the delegates. If any questions, definitely.
Okay, thank you so much.
Thank you, ma'am, for your valuable time and for the excellent talk. And we also thank all the delegates.
Okay, thank you so much. Okay.
Many thanks from the Shield team. Thank you, ma'am.
Thank you, ma'am. Thank you, Dr. Sameshwar.
Yeah, thank you, Bhargavi.